So, most excitingly, we're going to welcome our guest speakers for this month. So, Dr. Ryan Vandrey is an experimental psychologist and a professor at Johns Hopkins University Behavioral Pharmacology Research Unit and helps lead the Cannabis Science Lab. Dr. Vandrey's research focuses primarily on the impact of the route of administration, the dose, and the chemical composition of cannabis products and the resulting drug effects and pharmacokinetics. In addition, Dr. Vandrey has been involved in a broad range of studies related to assessing the risks and benefits of medicinal cannabis use, cannabis drug interactions, and the effects of cannabis on sleep, on cannabis withdrawal, and on the treatment of cannabis use disorder, cannabis product testing, and developing measures of cannabis use disorder. And joining him today is Dr. Johannes Thrul, and he is an associate professor in the Department of Mental Health at Johns Hopkins Bloomberg School of Public Health. His research interests focus on the intersection between technology, substance use, and mental health. And he's using technology to improve our understanding of substance use and mental health, and to develop mobile mental health interventions that help people change health risk behaviors.
All right, very good. I'm trying to move some things around here so I can see it. All right, so we're going to tag team this a little bit. I'm going to start out and give you all just a kind of a quick background on some of the work that Johannes and I have done to kind of get us to the point of the Cannabis and Health Research Initiative. And then we're going to kind of drill down on the details of what that is and what we're aiming to do. And as you'll see, there's a lot of overlap and complementary aims with our initiative here and what's going on up in Canada. And we really want to use this as a platform to help each other out. And I think where there's synergy, we should talk and collaborate. I'm already particularly interested in your AE tool that you're building. So my hope is that this is just the start of a longer conversation and collaboration between the US and Canada and these two different teams. So I've got some disclosures that I do some work, but I'm not going to get into that too much here. I'm going to try to kind of move fairly quickly through the background stuff here. I don't think anybody needs to know a lot of details here, but as we know, there's a lot of interest in the therapeutic use of cannabis for a variety of different health conditions. There's also a huge variety of different products. So when you try to talk about medical cannabis as if it's a singular thing, it becomes very problematic very quickly. So what we're trying to do is to try to capture this diversity of therapeutic intent, the diversity of therapeutic products, and to try to drill down and make some sense out of it. Now, the last attempt to do that was the National Academy's report in the US that came out going on 6 years ago now, where actually 7 years ago now, where they kind of did a systematic review of the evidence and the literature around medicinal cannabis. They found that there is conclusive or substantial evidence to support medicinal cannabis use for chronic pain, multiple sclerosis, nausea or emesis due to chemotherapy, a little bit of evidence for short-term use for sleep dysfunction, and then shortly after this is when Epidiolex and CBD was approved for rare seizure disorders. So that leaves a lot to be desired. And then I'd say the heterogeneity of cannabis product formulations, routes of administrations, and chemical compositions has grown even more. So we need to now kind of move forward and recognize that there's an urgent need for larger studies, for research on the diversity of cannabis products and specific cannabinoids, comparisons of medicinal cannabis to alternative treatments, to study whether this is a standalone treatment versus an adjunctive treatment for given health conditions, and really to try to better understand the science so that clinicians and patients can make informed decisions about product selection, about dose, about route of administration, and frequency of dosing that will maximize potential benefit and minimize potential harm for any given health condition and patient population. So what we're going to try to do is to try to fill in some of these gaps on a macroscopic level to then help reverse engineer things on a more microscopic level so we can kind of inform more targeted trials and research agendas. So what got me going in all of this was work with a nonprofit based in Colorado called the Realm of Caring Foundation. And they had, to their credit, been very interested in evidence-based information for patients and providers at a very early level. And they engaged myself and colleagues here at Hopkins and elsewhere to devise a longitudinal observational research study where we would collect data from medicinal cannabis users and non-users who were interested in medical cannabis. We would do an online-based survey with these folks at multiple time periods, basically surveyed people every 3 months for as long as they were willing to do them. But this was a very underfunded project, and we couldn't really provide compensation for people to do each of these surveys. So these were very motivated patients or caregivers who were filling out surveys that were fairly lengthy, really for no compensation. And so we ended up in this study as getting a fairly large group of initial engagement. I think from the start of this to in about 2014 or 2015 or so to now, I think we've recruited a little over 3,000 people to get at least an initial baseline survey. And then about 25 to 30% have filled out at least one follow-up survey. So what we end up having is kind of a cross-sectional comparison between medicinal cannabis users and non-users for a variety of health conditions. And then we have sub-cohorts of people who were non-users initially, then they started using cannabis. We were able to follow those folks prospectively and look within subjects at changes over time based on cannabis use condition. We also have a smaller subset of people who were cannabis users at the beginning and then stopped use for a variety of reasons. So we can look at kind of the impact of change in cannabis use condition over time and look at changes in health outcomes. So we've published a few papers based on an initial cohort of this study, and I'll show you just a couple highlights here. This first paper that was written by Nick Schlenz when he was a postdoc here took all comers and really just cross-sectionally compared cannabis users and non-users. And these were folks that were no different demographically, no different with regards to the types of health conditions they were seeking cannabis product therapeutic use for. But they differed based on whether or not they were actively currently using a medical cannabis product or not. Now, in this cohort, the type of cannabis product was predominantly a CBD dominant cannabis products, mostly oral dosages, but there was a variety of cannabis product use here. And like I said, a variety of health conditions. When we kind of compared these two groups against each other, we found that cannabis users reported greater quality of life, better pain management, better sleep, and better mood compared to non-using cohorts. We also saw that the cannabis users were using fewer prescription medications, had fewer emergency room visits in the prior month, and fewer hospital admissions in the prior month. So generally speaking, comparing across these two groups, the cannabis users tended to have better quality of life and better health outcomes and less healthcare utilization compared to the non-users. So when we wanted to drill down on this patient population a little bit more, a paper that was written by Justin Strickland focused solely on the patient population with epilepsy. And we didn't see a big difference in seizure control, but we saw a very important and clinically meaningful difference with regards to medication-related adverse events. This was a cohort of patients that were all children with rare seizure disorders and that were using an oral artisanal CBD oil. And in this case, the folks that were using the artisanal CBD had much lower adverse events related to their medication. And in most cases, they were using the CBD as an adjunct to traditional anti-epileptic medications. Another outcome, and this is a separate cohort that was focused only on the patients that were using medicinal cannabis to treat anxiety or depression as the primary health condition of concern. Aaron Martin wrote this paper and showed that the folks who were using cannabis at baseline and continued to use during follow-ups, this is a within subjects longitudinal evaluation, they showed improvement in anxiety and depression over time. These folks had better anxiety and depression compared with the non-users cross-sectionally. And then the cohort of folks that were non-cannabis users at baseline, but then initiated before the follow-up, showed the greatest reduction in both anxiety and depression. It was statistically significant, clinically significant, and the magnitude of reduction in anxiety and depression mapped onto the baseline differences in the non-users versus the users. So when you look at this across multiple ways, you can kind of make the case that medicinal cannabis use is having a meaningful effect on anxiety and depression in this population. We then followed that study up with a much smaller, more controlled observational study where we recruited 33 patients here in the state of Maryland who were newly registering with the state of Maryland Medical Cannabis Compassionate Access Program and were newly initiating cannabis. So these were folks who were not using cannabis when we first found them. They then initiated cannabis use, and we used a combination of surveys and interviews done remotely and iPhone app-based ecological momentary assessment questionnaires to look at the impact of medicinal cannabis use on anxiety or depression outcomes. And so these patients, because they were registering with the state access program, they were seeking high THC cannabis products, which is very different from our realm of caring patient population, which had predominantly used high CBD products. And you can see here on the left-hand panel, we had a variety of routes of administration. When people used medicinal cannabis, they reported feeling high after using across whether it was smoked or vaporization or oral dosing. But across the three routes of administration, we also saw acutely, so people were reporting their levels of feeling high and feeling anxiety before acute dosing in the white bars and then after dosing in the purple bars. And so within singular isolated episodes of use, we can see an increase in subjective feelings of an intoxication, but also a reduction in anxiety. We also saw acute reductions in depression. The effects in this study were dose orderly. So we get kind of an inverted U-shaped function where with oral dosing, looking at milligrams of THC, the sweet spot in terms of reducing anxiety seemed to be in the 6 to 10 milligram range. When you get to higher doses, 16 milligrams or more, you get more anxiety or less reduction in anxiety, and similar with reductions in depression. And then longitudinally, we followed these folks for 6 months after they initiated medicinal cannabis use. Compared with baseline before they started, they had clinically significant levels of anxiety and depression according to the Hospital Anxiety Depression Scale. And we saw reductions longitudinally that were sustained for 6 months. I'm going to switch now to Johannes for him to tell you a little bit about some of his EMA work now.
Great, thanks, Ryan. And I'll have you advance the slides if you don't mind. So this is the first of a couple of studies where we have also used EMA smartphone-based assessments in this particular case to look at cannabis use and opioid use among folks with chronic pain. And what I have on this slide here is this is based on an initial study with about 40 participants. We have followed this up with another study with over 130. So there's much more work there to come. But this is just to give you an idea of who these folks are, because initially we were interested in really just, folks who are using essentially multiple substances to deal with pretty severe chronic pain, even is it feasible for them to complete these relatively burdensome type of studies where we ask them to complete multiple surveys per day to get a better understanding of what their symptom load looks like, but also how these products are helping them or not helping them. And so here on the left-hand side, the graph is just baseline characteristics of patients. So this is an instrument called the Graded Chronic Pain Scale. And this is just to give you an idea that the majority of the sample was in this highest category of high disability, severely limiting chronic pain. So, by all means, we're getting participants in the door here that are fairly severely impacted. And then on the right-hand side, you see compliance data of these EMA surveys, and we get fairly high compliance, especially with the daily diaries, and some decent compliance with the momentary surveys as well. So next slide, Ryan. So we did a couple of studies. Now this is the first one that came out looking at co-use patterns and analgesic effectiveness. This was published in the Journal of Pain a couple of years ago. And you see here, we did daily diaries that ask about the entire previous day, and then these momentary surveys that just ask about the past hour. And on this bar, you see the different types of products that people are using. So in the daily diaries, you see that almost 50% of days, people are using both cannabis and opioids. In the daily diaries, cannabis only in about 30% of days, and then 10% of days they're only using opioids. In the momentary survey, so if we just ask like multiple times per day, we sample a random hour, we get a decent subset of observations again, where people are using both cannabis and opioids, cannabis only and opioids only. When we look at the analgesic efficacy of these products, what we saw, so this is kind of a longitudinal, if you will, like a micro longitudinal study that looks at on the previous assessment, what kind of products did they use? Does it impact their pain at the next assessment? And controlling for pain, like autocorrelation. We didn't see that cannabis or opioids or the combination reduced pain at the next assessment. What we did see is if we ask people about the perceived pain relief, so on this scale, this is a percentage pain relief, right? From 0 to 100%. So more is better here. And what we saw is that when we asked people about the perceived pain relief, this is in daily diaries, we saw this in the momentary surveys as well, that folks reported the highest perceived pain relief in co-use situations when they had used both cannabis and opioids, significantly higher than cannabis only and opioids only, but cannabis only also looked pretty good. So interestingly enough, so what this suggests to me is that there might be other type of treatment targets where people are reporting benefits from cannabis and opioids that go beyond the flat out just pure pain ratings, where we might be seeing, and I hear this repeatedly when I talk with patients, they say things like, maybe the cannabis doesn't help me reduce the pain per se, but it helps me take my mind off of the pain and improve the health quality of life that way. So what this suggests to me is that we need to do more work in figuring out like what the treatment targets are and what the variables are that people sort of report effects on.
Yeah, so I think what that highlights is kind of some of the early data that Johannes and I did just kind of leading up to this, and in that we're able to kind of bring together complementary areas of expertise in terms of experience with web-based surveys, with the use of ecological momentary assessment. We've done some targeted things with particular health patient cohorts and health conditions, but it's been relatively small. Okay. So another area that I've been looking at with a couple colleagues is quality control issues, right? And so there's in the US, there's a lack of standardization with regards to how products are manufactured or tested. A lot of labs don't have the right quality control standards and things like that. And there have been a number of cases of contaminated products being reported in the industry. We've done a number of studies looking at dose label accuracy and just the variety of products with regards to chemical composition. So one study looked at CBD oils that were purchased over the internet and showed not only that dose label accuracy was poor, but that products that look the same, come in the same size bottle, and are largely labeled with the same kind of content have a huge range of actual cannabinoid content. So in these CBD oils, we found a range of 1 to 800 milligrams per milliliter of liquid. And that's an issue for patients that they don't always understand that nuance. In cannabis edibles, we saw poor dose label accuracy and again, a huge range of doses. Now, this is an older study and a lot of regulation and policy has kind of reined this in a little bit, but it still exists in some markets. Then most recently, we did a topical CBD product testing study and a study looking at cosmetics and food products. And again, poor dose label accuracy, huge range of cannabis content within these products, and a lot of label claims that are really unsubstantiated. And so we're mindful a little bit about product surveillance as we're thinking about research, science, and education related to medicinal cannabis use. And I mentioned contamination as being an issue before, and the contamination can come from a variety of sources. It can come from heavy metals in the soil where the plant was grown. It can be residual solvents from the processing of the plant material. It can be, a number of other things. It can be mold or fungus or things growing if the samples aren't stored properly. So all of that kind of background leads us to our current Cannabis and Health Research Initiative. And this is a large grant that we got from the U.S. National Institutes of Health to kind of bring a lot of this stuff together under a single umbrella with a well-funded, larger initiative where we're kind of piecemeal a lot of this stuff together into a singular kind of unified project and initiative. And so I'm going to kind of let Johannes take back control of the mic and talk through some of the different pieces here. But the idea is that we're taking what we've done in the past, we're bringing more people in and doing things better and bigger.
Great. Thanks so much, Ryan. Yeah, and I'll talk about all of these in the next slides. Great. So it's a large study with a substantial team with Ryan and myself here at Hopkins, a bunch of collaborators here at Hopkins. You've already heard a little bit about our kind of complementary expertise. I always say, like, Ryan is the lab scientist who does these like super well-controlled studies, nitty-gritty, where you have a lot of control over all of the variables going into this. And I'm more of the messy real-world data collection where we get, what people do in the real world, but it's really messy and it's hard to control. And so ideally bringing those, those different expertises, but also the different studies together can help us build something that is greater than the individual pieces involved. So here at Hopkins, we have folks at the Realm of Caring Foundation. Ryan already mentioned the ORR work that he has done, wonderful collaborators, a large team of external partners, consultants. And I'll talk about the different sub-studies on the next slide, but maybe here just to say that we have folks, obviously, like, Ryan and myself, but also people who have expertise with large-scale observational studies, registries, folks with expertise in computer science, natural language processing, AI, all things that are needed, and that will become clear on the next few slides. So the main data collection, prospective data collection, will be a study with 10,000 patients where we get them at baseline through mostly collaborations with, for example, there are these platforms out there that are kind of the matchmakers between patients and providers when folks are seeking a medical cannabis recommendation. So we get them in the door as they are naive, where they're just starting or intending to start using medicinal cannabis for any kind of health condition. So we're really taking all comers, and we want to make sure that we're getting a good representation of different conditions. And then we're really doubling down on assessing the early phases of the medical cannabis use journey. So we're doing a baseline 1 month, 3 month follow-ups on REDCap, and then a 12-month follow-up. So this will be the 10,000 patient main cohort. We're also doing sub-studies with 500 patients that will complete ecological momentary assessments around these assessment time points for 1 week each. So bursts of EMA assessments. We'll select folks with primary conditions. So the main prevalent conditions that people are seeking medicinal cannabis for here in the US, which tends to be pain, anxiety, insomnia, and PTSD. So we'll get a lot more detailed data from them on what Ryan already described, the pre-post cannabis administration, how they're doing, what the effects they have. Currently, we're looking into how can we make our AE assessment more robust. So my ears perked up Lauren, when you started about your AE tools. The second sub-study will be biospecimen testing for cannabinoids in clinical chemistry. So we'll send people into the lab for biomarker assessment. That will be with 250 people. And the third sub-study will be cannabis product testing, where we will likely also prioritize folks who have reported AEs in any of our registries. Ryan, next slide, please. So all of these data will come together there will be a lot of data integration that we have to do to inform. In the top, you see the sub-study 3 cannabis product testing, but also in the middle, data harmonization, where we'll pull in data from the existing ORR, pull in data from other contributing partners. If folks have data that could be of interest here, we're very happy to include them and make them accessible. And there will be opportunities for folks to apply for both getting access to the data, but also research funding. So there'll be a pilot program. And we'll talk about this paper that we just put out. This is a paper that we just published in Nature Medicine to show the kind of large-scale observational efforts that are needed to really move the needle on this. Ryan mentioned, obviously, the complexity of the cannabis products that are currently in the market make it really hard to determine where the signals are and which products to even move into clinical trials. And there is a wealth of data, for example, that is out there in electronic medical records that is currently untapped, and cannabis product, especially medical cannabis product use, is not particularly well documented. So in this paper, we kind of put a flag in the ground to say, this is the type of information that needs to be collected by providers to make sure that we will be able to determine what the kind of products are, the cannabinoid chemotype, but also route of administration and dose that is needed to then go into electronic medical records. And then we can construct really robust studies looking at case controls. What are people using medical cannabis for? What kind of products are they using? And we're doing some work here at Hopkins to get some of these kind of assessment instrument flow sheets, things like that, into Epic, so providers can start documenting this, and hopefully over time we'll get other health systems on board, because there's really a lot of work that needs to be done here. And what we're working with also is natural language processing, like computer scientists here at Hopkins, who will help us build natural language processing tools, because until we have these more robust assessment methods in the electronic health records, we're reliant on the provider notes, text data, right, that we need to sift through to get at whether or not folks are medical cannabis patients, and see what the type of information is that providers are including in those notes. So that's the other challenge here. So if you're interested, check out our paper and let us know if you have any feedback. That would be very much appreciated. So I already mentioned there will be a data repository. So all data collected under this initiative will be deposited for academic research. So make sure this is on your radar, and there will be so much data that no team will be able to analyze these data. And there's a lot of, obviously, folks have a lot of talents and expertise that go way beyond of what Ryan and I know and our team knows. And I think obviously everybody is needed in this kind of area to move the needle. So there will be a grants program to support junior scientists, to provide pilot funding to get more people involved here. That will launch hopefully at the end of next year, as soon as we have some robust data that people can use. And then we're working on cannabis assessment development. Ryan, I wonder if you want to take that one and the next to talk about the tools that we're developing there.
Yeah, sure. So while we're working on kind of getting the larger initiatives and the studies launched and kind of collating enough data to start working with, we've been very mindful of the need for developing some new assessment. So similar to the AE tool that you all are working on, one of our biggest gaps in that we've identified is a validated, modernized tool for quantifying cannabis use, right? Because there's so many different types of cannabis products, different routes, different assessments, different units of measures across these things. And so within the context of the Realm of Caring project, we kind of created something that was really sophisticated and I think captures the entirety of the current cannabis market. And what we're doing is doing validation testing on that assessment now, and working on a publication to get it out for other people to use. Because currently everybody is measuring cannabis use differently and not very well. In addition to that, we're working on a core assessment battery. So part of the repository is, it's great if we have a single hub. There's lots of data, but if it can't be harmonized, it's not very useful. About 5 or 6 years or so ago, I gave a talk at the ICRS meeting about the need for a core and common assessment battery for observational cannabis studies and cannabis clinical trials that captures some just essential health and quality of life functions. And so we've brought that back here and are again working on a publication to make recommendations that show the rationale for the measures that we selected for both the ORR and for this new CHRI observational studies, and really to encourage other researchers to adopt the same or very relatable and relevant assessments, so that when it comes to depositing into the repository, it's easier to integrate and combine data sets to make the analyses more powerful and more robust. So really focusing on kind of key metrics such as substance use, mood, sleep, quality of life, daily functioning, healthcare utilization, motives for use, expectancies, and again, cannabis use behavior. And then also ancillary assessments for specific common health conditions for which people are often using medical cannabis. So with that, we're going to kind of wrap this up to try to leave enough time for discussion about this. But I think that kind of where we're at now is we're really looking for engagement from other folks. We think that the data that we're going to collect as part of this project is really going to move the science forward. The integration of this with regards to multiple modalities of research and science and data collection is going to be incredibly valuable. The magnitude and scope of this is going to be really good and probably bigger than most other projects and initiatives. But most importantly is we're intentionally building this to be a platform for multiple projects. And so we really want to encourage people to say, hey, this sounds great. We're very interested in this particular patient population using for this particular health condition, or this population using this particular product. Can we use your platform? And so we don't have to build it ourselves. And that's why we're doing this. So we're really open to not only sharing our data with other people, but sharing our platform. So if, for example, we've got funding and a plan to recruit 10,000 patients, but if someone else had funding to pay another 5,000 patients and wanted to say, we really want everybody with autism to do this study and be part of this study, we want to oversample this particular population, we're happy to share the link and grant access to that data if you help compensate the people for doing the study. So there's lots of ways in which we can work with other folks to do that kind of stuff. So Johannes and I are by far not the only folks participating here. So again, we want to thank everybody else that's involved. The slide Johannes talked through earlier showed most of the other folks at Hopkins and Realm of Caring, but also I want to make sure we recognize that we have active at NIDA. Heather Kimmel in particular is the scientific officer who's assigned to this grant and has been instrumental in not only developing this idea, but helping us get things going. And then our partners on the industry side, Mahmoud El-Soli, his laboratory will be doing all the product testing, and Veraheel is one of our key contributors for engagement with patients. So we'll wrap that up there and open it for discussion. And knowing that we only have about 10 minutes till the end of the hour, if there's anybody who has any thoughts or wants to do follow-ups or additional questions, our contact information is here. And if you want more detailed information about us and what we're doing, this cannabisandhealth.org is the website for the Cannabis and Health Research Initiative. If you're interested in some of the other stuff that we do, JHUCSL can steer you through some of the lab studies that we do.